Okay, good afternoon. We'll get started. Several people ask me from time to time, why do we pass these books around and record, write down? It's not really to keep track of attendance per se. If you attend at least half the sessions and then pass an electronic final exam that we give, which is not something that you're going to lose a great deal of sleep over, and you can take it several times. So if you do that, you get a certificate. And for some people, that's of some, hi, Kathy. For some people, that's of, real interest and importance, particularly postdocs or students. You get what? Okay, that's for the, yeah. But the reason why we do it, it's a very interesting phenomena. For example, if there's a topic on the first session that deals with infectious diseases, there's a huge number of people from the Allergy and Infectious Disease Institute and others who come. And then let's suppose that the next week is, I don't know, multiple sclerosis. Well, what's very interesting is that 25% or so of the people who came for the ID lecture come back the second week. And then there are a wave of people from NIAID, and about a third of them and from the first group come back. So we're interested in finding out, what is the learning experience? Why do people do this if it's not in their specific area of discipline? And there's a graduate student who's writing a graduate thesis on the subject of 11 years of data like this and then interviewing people. So it's quite revealing. Okay, so today we're going to have a discussion of pertussis. In my reading about this, I was very intrigued to learn that it has expanded its scope from being a disease of newborns and infants, that more and more adults are affected by infection with Bordetella pertussis. And so the spectrum is changing. And I keep wondering, how many internists, well, I don't know how many internists even recognize it when it appears in an adult population. But there are very interesting questions that arise regarding prevention, effective vaccine, what is an effective vaccine, and so forth. And so these are going to be the themes of sort of today's presentations. So we're going to lead off with Alexander Freeman. What, John? Alexandra, that's what I said.
No, you said Alexandra.
My pardons. As you can see, my best friend and severe conscience is here in the audience, so I have to watch what I say. Alexandra, pardon me. So Alexandra graduated from Georgetown Medical School with honors, trained in pediatrics at Yale and New Haven, and then at Northwestern, and came to NIH in 2004 in the clinical center, where she's a staff clinician, and has done really a whole series of remarkable studies, not specifically with regard to pertussis, but has a considerable experience in the broad areas of pediatrics. And then our second speaker is my older brother, John Robbins, who is, now you can close your ears, John, is a hero to many of us because through the years, he and Rachel Schneerson have here at NIH. Before that, we first met at Albert Einstein many, many years ago. But while here at NIH, they developed a series of vaccines, particularly against Haemophilus influenza type B, which have had just dramatic effects throughout the world. I don't know how many hundreds of thousands, or maybe it's in millions, of children who have been literally protected by this vaccine from even the lethal effects of infection with Haemophilus influenza type B, the bacterium, not the virus. And they have developed vaccines against a variety of other major infectious diseases using novel techniques and the great perseverance that was necessary in order to bring these things into the applicable world. It's not enough just to do something in the laboratory. Sometimes the hardest work is what follows before it can be brought into clinical practice. So in acknowledgement of this, John and Rahel received the Albert Lasker Award for excellence in clinical medical research, the WHO Pasteur Award, the Albert Sabin Gold Medal, members of the National Academy, et cetera, et cetera. So it's a great pleasure, brother, uncle, grandfather, to welcome you back for the second speaker. Okay, you can talk about that too. So, Alexandra, thank you.
Thank you so much. Oops, let me turn this on. So I'm being told to do. The microphone, I do have a little bit of a viral thing going on, like a little laryngitis. So hopefully everyone can hear me okay. I really do not think I have pertussis. I was vaccinated a few years ago, and I should be okay. So anyways, it's great to talk about pertussis because my training is in pediatric infectious diseases. And over the years, I've seen through being a pediatric resident and through my fellowship and on and off since, have seen individuals with pertussis, anywhere from babies to some of our adults who come in. And it's kind of getting me more back to my roots of my training to talk about this. I wanted to start with a video of a baby that has pertussis. I know sometimes in this course, I spoke a few years ago, and I brought in a patient who had had a staph infection. Unfortunately, I didn't have someone to bring in with, we don't want someone sitting here with pertussis, and I didn't have someone recently in the area with pertussis, but I thought showing a video of the baby who really has the kind of full-blown disease would be beneficial for everybody. This is actually from a vaccine kind of film that was produced in Australia called Jabbed, and they're making a version that's going to be on PBS soon. And one of my friends is actually one of the producers for it, and I was able to connect her with a pediatric infectious disease doctor that I trained with, who was able to access and find a baby for them to film. So I was just going to show this quickly, and then we'll start talking. Oops. Oopsie. Uh-oh. Oh, no. Maybe here we go. We're going to show the part, this is up.
Then someone, somewhere, passed a dangerous germ to Osman, their newborn son. And suddenly, life went
That's the baby of interest. So here's a baby when he was just a month and a half old with pertussis. And what's really hard about this is there's not great therapies when you're like this, when the baby's sick and coughing like this.
Osman Chandab is 7 weeks old. He was due to be vaccinated against whooping cough in the next week. But the germ has got to him first. His mother, Jumana, brought him to hospital 2 days ago. What started as a runny nose and a slight cough has become frightening episodes where he's struggling to breathe.
The babies are often brought to the hospital so they can be suctioned because it's hard for them to cough up the thick mucus. and also to give them oxygen, because the main complication is babies is that they stop breathing and their oxygen levels go down.
From Monday, he started to change his color, turning to blue, and he lost his breathing. My cousin, she held him and took him out the room, outside to fresh air, and tap on his back to get back to normal. And my other cousin, she called the ambulance. The ambulance came in straight away. So they do all the kind of blood tests to see what's that from, and after they find out that's the whooping cough.
Pertussis, he had some pneumonia, so we do need antibiotics.
Whooping cough, or pertussis as it's formerly known, can be life-threatening for babies. 1 in 4 babies hospitalized have serious complications, like pneumonia. 1 in 250 die. There's no medical cure. Antibiotics are used to reduce the chance of infecting others, but Osman's tiny body must fight the infection.
What's he weigh?
4.5. Anyways, I think that gives you the flavor of this illness. And a representative of the babies that us as pediatricians have to bring into the hospital sometimes and see in kind of this helpless state. Okay, let's see if I can get this back up to the viewing. Oh wait, I can do right there. Can I? Okay, more of a Macintosh person, Mac person. So anyways, I was going to talk a little bit about the history of pertussis, the microbiology, the clinical features, diagnosis, treatment, some of the impact of diagnosis, but then the other speaker will speak more about the vaccination. But I'll talk a little bit about other Bordetella species and just kind of touch on vaccine-preventable illnesses. So pertussis is a very old disease that has gotten a lot of attention in recent years when we've seen this kind of increase in incidence as the adolescents and adults have been recognized to have more infections that are then being passed on to the babies. It was actually first recognized in the Middle Ages as the kind, which is Scottish for paroxysm, because there's these great paroxysms of cough. The first epidemic that was actually written about and described was in 1578 in Paris. About a century later, actually Sydenham named it as pertussis. So I don't know if you've ever discussed rheumatic fever here, but Sydenham chorea is what Sydenham is better known for. And I didn't know about that he was actually had named pertussis, so I was looking this up. The bacteria was isolated in the beginning of the 1900s, and the vaccine was then developed in the 1930s, which made a huge impact in terms of the incidence of this disease. But recently, there's been this resurgence of the infection that now we're beginning to get under more control again. So what is pertussis? Its name is Bordetella pertussis. It's a gram-negative rod, and it's very fastidious, so it's hard to grow. You need special media. It needs media that has some charcoal in it to grow. It takes a little bit longer than strep. And it only affects humans compared to some other Bordetella species. And I'll talk about some of the other species later of Bordetella. And it doesn't have a known environmental reservoir. So it's actually an infection that would be quite amenable then to vaccination, because it's not something that's coming from either animals or the environment that is harder to deal with vaccinations. And its pathogenesis is really driven by several toxins that contribute to the disease, which I'll just touch on a little bit. So this was kind of a cool 3D image of the cilia, and you can see the bacteria there in green. When you get infected with this, the bacteria actually attach to the cilia, and with some adherence factors, filamentous hemagglutinin and fimbriae, which are actually targeted in a lot of the vaccines and probably will be discussed later. And they actually then do paralyze the cilia through some of the virulence toxins. So this is a bacteria that really uses a lot of toxins, and several of these toxins are actually then targeted in the vaccine to create the disease. Several of these work against the actual chemotaxis of the inflammatory cells, like the lymphocytes and the neutrophils to the infection, and others work more on the actual cilia and the respiratory epithelium, causing the cells to kind of slough off into those small airways. So I listed some of them here. Adenylate cyclase, which is involved in making the white blood cells, the neutrophil and lymphocytes not actually go get the bacteria when it's sitting there on the epithelial cells, the respiratory epithelial cells. Pertussin toxin, which is kind of the most famous of all the pertussin toxins, and that one's always been targeted in the vaccines. That one binds to the cell membrane, again, works also on the chemotaxis, but also is involved in other areas throughout the body. I thought this was interesting, learning about this, how it can actually affect the pancreas and can result in kind of a high insulin state. And if you have too much insulin, then your glucose goes down and can make the babies a little bit more hypoglycemic. This actually also causes this big lymphocyte lymphocytosis. So in the CBC that you see in these children with this infection, in terms of the blood counts, you see this really, really high lymphocyte count compared to bacterial infections, where you see other bacterial infections like pneumococcus or other causes of bacterial pneumonias, where you see lots of neutrophils. And then there's tracheal cytotoxin, which actually damages and kills those ciliated respiratory epithelial cells and causes them to actually slough off into the small airways. And that then contributes to the really thick mucus that these babies have, both the white blood cells, but also the airway cells actually coming into the small airways, really kind of obstructing that and making it very difficult to cough out. So in terms of the clinical presentation, this is a very contagious bacteria. When you have someone in your household that has pertussis, about 75–80% of their household contacts will actually get infected if they're not vaccinated. And then there's a good week or 10 days before you actually get sick. And the beginning of the illness is called the Qatari Stage, and that's more just like a cold. And that's a problem because this is when you're super infectious. So when you're kind of infecting everyone else, you're acting like you have a cold, which is why, in the back of my head, I'm like, better not have pertussis when I'm talking about this. So these individuals will have, just a runny nose, kind of red eyes, you're sneezing, coughing a little bit. But really that beginning phase is a little bit more like a cold, and most people would not recognize this as pertussis. It's really rare to have fever. Again, it just acts like a regular cold at that point. The next stage is kind of the more classic, you start thinking about pertussis stage, the paroxysmal stage. And this goes on and on and on with the cough, 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 and led to this kind of name of this illness as the 100-day cough. So the first few weeks here are very contagious, and then either through the antibiotics or through your own immune response, the bacteria is actually killed and people become less infectious after the first few weeks. But this is where you have these horrible paroxysmal cough when you're trying to clear out that really thick mucus, as I said, is made from the respiratory epithelial cells and the white blood cells kind of in those small airways. And so what you have is the cough, 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 and then the big whoop, which I can't do with my voice right now, as you're trying to catch your breath to have another big series of coughs. You're trying to get that really big kind of airway pressure in, and then cough, 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 cough. And this is usually really, really bad at night, and as I said, goes on for weeks and weeks and weeks. Again, things like fever are not that common, but this can have a lot of complications at this phase, including a lot of people kind of classically throw up at the end of those long bursts of coughs. And then you start to get better. So for the next couple of weeks, it's called the convalescent phase, and those paroxysms go down and down in terms of frequency. But at that point, if you get exposed to something else circulating in the community and have a little infection, with one of the common colds, again, you can enter that phase of having paroxysms again. You can see the poor baby there with these horrible coughs. But what we've recognized over the last series of years is that atypical presentations are really common. So in adolescents and adults who are vaccinated when they were children, they have some protection, and they often don't have that classic case and those classic kind of paroxysms of cough. So they can be much more mild, and that's why it's missed and then can be passed on to the babies who are not vaccinated. And in babies, like when you saw that teeny little baby with all that coughing, they don't have that chest strength to come up with those big whoops. They can't make that high inspiratory pressure, so they don't have the whoop. And unfortunately, they then have more because they don't have the pressure to really get that thick mucus out, they end up having more periods of apnea where they actually, have their oxygen levels go down and they stop breathing. And that leads to lots of complications. So about half of babies will end up being in the hospital, mostly because they just can't clear those secretions and their oxygen levels go down. 2/3 of them with apnea, that means, they stop breathing. About a quarter of them with pneumonia, either from the actual pertussis or from other infections than as a co-infection. And small numbers with seizures or encephalopathy. There was a lot of discussion over many years about whether or not that was toxin-mediated or not. It's thought more to be related to the oxygen levels dropping, leading to either seizures or brain damage from that. And 1.6% of babies will die from this. And there's lots of complications when you're coughing that much and having all those changes in your pressure inside your chest. You can see the child here has the subconjunctival hemorrhages from coughing, having that high pressures, bursting small blood vessels, and the kind of the bruising underneath the eyes from coughing. Sometimes you can drop a lung, having pneumothorax, from having all the pressure, other things like hernias or rectal prolapse. Pulmonary hypertension has actually been found to be pretty common in the babies. So when your oxygen levels are low, then the pulmonary, those lung blood vessels constrict, and the right side of your heart has to work then harder to get the blood through to the airways. And rib fractures from coughing so much. So why is this such a problem for babies? The incidence in recent years was actually a lot the adolescents, the young adults, who were having so much infection, and that made people realize that the immunity was really beginning to wane off, and these people were really the reservoirs. But it's the babies that end up in the hospital, and it's the babies that are dying with this illness. So a few reasons. One is, we start vaccinating the babies at 2 months old, but their initial immune responses are not that great. And a lot of these babies are getting sick even before they get their first vaccination. But for that first year, their immunity is not as good as children later on. And then moms, through the placenta, pass on a lot of immune globulin to babies. But if the mom hasn't been vaccinated in a while, if the mom wasn't vaccinated since the mom was a child, then that baby didn't have that maternal protection, which is why now we're beginning to target actually pregnant women. And with each pregnancy, they're trying to vaccinate the mom to actually give that transplacental coverage for the babies. And as I said, the babies don't have the strength to cough out the mucus. And then babies get sick a lot. So, all you need is pertussis and then have like RSV, which is a very significant viral infection for babies at the same time. And you have a double hit and a lot of trouble with oxygen levels. So some is known about the pathology of this illness because of fatal cases. Often there is some sort of pneumonia, so the smaller airways that are then involved, either with pertussis or with other bacteria causing a secondary infection. And the airways, kind of those smaller airways and the bigger airways, get filled with this inflammatory debris, as well as all the respiratory epithelial cells that have sloughed into the airway. Pulmonary edema is very common and bleeding. And they think a lot of that is actually from the hypoxia, leading to kind of the swelling in the airways and the swelling in the small vessels. And you can see here's a bronchus. This would be an airway, a bronchial airway. And this should all be air with no cells inside there. And this is all filled with epithelial cells and with inflammatory cells. You can see, so this is what those babies are trying to cough up. So how do we diagnose pertussis? The main thing is just making sure that someone actually thinks about it. When you have an adolescent or an adult coming in with something you think of as a childhood illness, that you actually think, this cough has actually gone on a little too long, and looking for pertussis. The kind of gold standard has always been culture. Now, we have all these fancier techniques that are a lot more sensitive. So culture is becoming less common compared to the PCR. But the culture is a little bit tricky. You kind of have to get a special type of swab. You actually, here, we get the media, we bring it to the clinic, and we actually put the swab immediately in that culture media. And that culture media, as I said before, these are hard bacteria to grow. They're a little bit fastidious. You need to have that charcoal in the media. It actually there's a lot of bacteria that are in your nose, like staph and streps. And so the media actually contains antibiotics to kill some of the other bacteria to really let this bacteria grow. So if you grow it in culture, it's extremely specific. You grow it, you can identify it, everything is good. But the sensitivity is really not great. And over time, after those first couple weeks of illness, the sensitivity goes way down in terms of diagnosing by culture. So, those first couple weeks when you just act like you have a cold, no one will think about it. Then you only have a week or two to really get your diagnosis by culture. So PCR is being done much more commonly now. And when we send this from the clinical center, we actually send PCR as well. And then, with PCR, you can actually pick up the dead bacteria too. So if the person's on antibiotics or if the immune response is actually getting that bacteria to be less viable, you can still pick this up by PCR. So then your sensitivity goes way up, and it's pretty specific. There's a little bit of cross-reactivity with other Bordetella, but it's still pretty good. And that kind of puts you a few more weeks into diagnosis period. Serology is looking at the antibodies, looking at the antibody response to the actual infection. And this is done much more in epidemiologic studies than actually in diagnosis. In part, it's a little bit tricky. Someone comes into your office, you get an antibody. If that person had been vaccinated at some point, it might be positive. What you really need to see is, a not as positive antibody, and then 4 weeks later seeing a much more positive result as that response goes up. But if you're just trying to capture someone in clinic and diagnose them, it's a lot more difficult. So it's used more epidemiologically. Just kind of, in the clinical setting also, we often get blood work and a CBC. You see these super high lymphocyte counts. And if we get a chest X-ray, most of the time it's normal. This just shows a little bit about that timing, as I said. With cultures, those first couple weeks of illness, we're not even thinking about it because it hasn't gone on that long to really, really think about it. PCR gives you a little bit more time. Your third week of a bad cough, someone starts thinking, okay, maybe this isn't just, a cold. Serology is later on, but as I said, that is used much more for epidemiologic studies. And I just, want to throw in, too, that, compared to the flu, this doesn't have the seasonal variation as much. It's not like a pertussis season. And there seems to be these kind of outbreaks every several years. So how do we treat pertussis? Again, kind of the quicker you treat it, the more impact you can have. So you got to think about it. And if you really think it's that, actually start treating even before your test comes back, because some of those tests will take several days to come back. Because after the first couple weeks, you're not going to really impact the illness at all. That's what they were saying in that video. At that point, when the baby's been coughing for a few weeks, actually, that's more the inflammatory response then and causing in the kind of sloughing of the epithelium that's causing a lot of the symptoms. The actual viability of the bacteria is not as important, several weeks into this illness. So you need to treat early if you're going to actually affect the actual patient's symptoms. But we still treat, because if there's any bacteria there, you want to make sure all those bacteria die so that they do not pass on to other people. So it's important to treat more for the infectivity after the first couple of weeks, which is when you usually pick this up. And pertussis is killed within about 5 days. So, within that period of time, the person's back at, work, at school, or, I'm sure, myself and many other clinicians have taken multiple courses of erythromycin when we saw people in clinic, didn't realize, and then ended up, the person had pertussis, and we all end up on antibiotics. So we usually treat this with azithromycin is given most commonly. That's like a Z-Pak. It's a pretty common antibiotic to give. It's very well tolerated. Kind of some of the other macrolides, that's the name of that class of antibiotic, clarithromycin or erythromycin. Erythromycin was kind of the older one that people used to get, but it's not as well tolerated as the newer antibiotics. If someone can't tolerate them, then Bactrim can be used. But, unfortunately, there's not great treatments for the actual cough. Giving like a neb treatment of albuterol like we do for asthma, it doesn't really help. Steroids don't really help. It's more oxygen, fluids, nutrition. And then post-exposure prophylaxis is important. So when you have someone that's diagnosed with pertussis, making sure that those around that individual get treated. So, the clinicians that were taking care of the patient, if you weren't wearing a mask, and other high-risk individuals. So usually the household contacts, pregnant women. The pregnant women is not that pregnancy has a worst case of pertussis. It's to make sure that the person's not infectious when the baby's actually born. Individuals that are immunocompromised. And it has, as I said before, it's very contagious. It's a very high household contact, household attack rate. And it's pretty sturdy. I found that statistic that can survive in dry mucus for 3 days, which seems a lot. So just one thing that, happened back when I was actually in my training, so we all talked about it a lot at the time, was there was actually an outbreak of pertussis. There was an exposure in a neonatal intensive care unit. So they ended up giving, all these other babies that were in the NICU erythromycin for prophylaxis. And then a few weeks later, there was this big spike in pyloric stenosis, which is the outlet of the stomach. It's hypertrophied and thickened, and then the babies come in throwing up, and it's a problem, and then they can have a little surgery, and then they're fine. But they did a study with the CDC at the time and actually linked erythromycin to pyloric stenosis. And this has been true in other cases as well. So since that time, the babies now are supposed to get azithromycin. Who knows? There hasn't been that many outbreaks in NICUs to really tell whether or not that will have the same risk. But it was kind of an interesting association. Erythromycin is a pro-motility medicine, so we use it sometimes clinically if people's stomach and intestines are kind of not moving quick enough. We do it to kind of move things along in the stomach and intestines, so it kind of makes sense that it could affect things a little bit there. So, why do we care now about pertussis? This is an ancient illness, we had this great vaccine. Well, in recent years, this has actually become a really big problem again. And in 2012, they reported the most cases since 1950 of pertussis. Now, some of that is that we have better, we have PCR now, and they didn't have PCR in 1970 to diagnose pertussis. And some of that is recognition of these kind of atypical cases. But some of that is also because of people not vaccinating as much, fears of vaccination. But, in the last, a couple years ago, there was 41,000 reported cases and 18 deaths in our country. I mean, that's a fair amount, and the deaths are all mostly in the babies, the very small babies who haven't gotten enough of their vaccines. And the increases in cases is more the adolescents and adults who have this more atypical case, or atypical course. And there's a couple states where there was kind of these outbreaks that kind of skewed this data. But it's actually, it's not uncommon. They did some of those serologic studies in the 80s and 90s and found up to a quarter of the adults who came in for cough going on for more than 5 days actually were positive and seemed to have pertussis. So, I think it's just this greater recognition in recent years that, this is a big problem, and realizing that, for those of us who are vaccinated as kids, that vaccine immunity really did wane, and now all of us are going in and getting our new shots to get protection. And it's just showing pertussis over the years that, the initial vaccines were 1930s, and then they got better and better vaccinations, but, it really worked. I mean, the cases really came down, and everything was really good until recent years. You can see here with the more than 18-year-olds going way up, and the different ages with that kind of increase. And also, the babies are what we worry about because babies are dying with this illness. But it also has a big kind of economic impact. It has a big impact on, the kids who are in school. They did a study in Massachusetts and saw that, most of these adolescents and adults were seeing the doctor twice for this, that about 80% of both missed work or school, a lot of work, like a mean of 9.8 days in the adolescents, like 5 days of school, which is a lot. And the parents of the adolescents are missing work, so it has a bigger kind of socioeconomic impact. And then it's also a huge international problem. The numbers that we're discussing in this country are nothing compared to around the world, where this is much more endemic and the vaccination rates are much, much less, and there is many more deaths, 195,000 deaths a year in children. So I just wanted to mention a couple other kind of similar to pertussis, because sometimes, this actually comes up too. And I think more and more in recent years, now that we have better ways to identify bacteria, we're actually recognizing more of the other Bordetella species. So I put this in actually because Bordetella Parapertussis, because one patient that I saw a few weeks ago who had scarring in his lungs, called bronchiectasis, this kind of chronic infection in the lung, who's also a smoker. And he came in actually doing fine, but with his usual chronic cough, and I got a sputum culture, because he's actually having surgery today on his spine at a different hospital, so I wanted to make sure I knew exactly what was there so I could treat it. And he grew out Bordetella Parapertussis. This is actually a more mild infection than pertussis, but it's pretty similar. It has less of kind of all those toxins with all that, kind of some of the more pronounced symptoms. It's usually shorter course, less severe, doesn't have that big lymphocytosis. The culture is a little bit easier to grow. The management's less clear, but you know what? Even if you don't give them the perfect antibiotic, these individuals tend to get better. I gave my patient a fluoroquinolone, levofloxacin, and he was doing fine. And hopefully he's doing well in his surgery today. They've also recognized that some of the more severe cases, though, of pertussis actually have had co-infection with Bordetella Parapertussis. And then this one is something that we all come across probably even more than pertussis, Bordetella bronchioseptica, which is kennel cough. But this actually also can infect people as well. So really common, where dogs, when they're off, hanging out together, but can also infect, and we see it every couple of years in our individuals who also have that kind of chronic lung disease and the immunocompromised host that I often see in my clinical practice. And I think we're even beginning to recognize more and more Bordellas that we never thought were pathogens that are causing a problem. This is actually from a patient that, I'm not on the paper, but I was involved with this patient. I was in our clinical group and was admitted here. And we recognized that the patient had Bordetella petri, complicating her underlying disease, and actually looked and saw these that her immune responses, she was actually increasing her antibodies, that she was actually responding to this as a pathogen, and she would get better when we treated her. And then I just wanted to end by highlighting that, I think pertussis is a good example that there is a reason that people have done these vaccinations, that people come up with these vaccinations. And, I think those of us like me who have done our training in the post-vaccine world where we don't see these infections, then we hear about these coming back every once in a while and, sometimes need to be reminded how severe these can be. This is measles, and just showing, there are measles cases reported every year. And I thought what was interesting here, I got this from the CDC, was that this is kind of the imported ones in this color. And these are ones from our country. You can see these kind of higher incidence of measles actually, being transmitted in this country. And they estimate if people stop vaccinating that about 2.7 million measles deaths would happen each year. And still, measles is an infection that people can die of, that they are dying of around the world. And even in our country, 3 out of every 1,000 with measles would be expected to die. Mumps has been in the news a lot over the last several years with outbreaks happening in kind of close quarter communities, either in colleges. There's an outbreak in New York and some of the Orthodox communities there where the vaccination hadn't been complete. But you can see here kind of this resurgence, a little bit of mumps. And that, sometimes, with vaccination, we can make some of these diseases almost obsolete. There's been the polio. They've been trying to eradicate polio, and you can see from the, amazing progress. And there's the oral polio vaccine that they're using now to target some of these remaining countries with polio. And of course, it's always important here to get our flu shots. So thank you very much. And now I think we're going to hear a lot more about the vaccine.
Thank you very much, Alexandra. That was very, very helpful.
And I made it with my voice not working.
We have some questions or comments? Yes.
You had a statistic on the incidence of measles without the vaccine. What would be the incidence of whooping cough and the number of deaths if no one was getting vaccinated?
Yeah, that's great. We can go back and see. I have some of the I didn't have all of that here because of the because I thought it would be highlighted more in the following. Here we go. You can see here though that the incidence. This is per thousands. So these are the years here that were before vaccination. So with the incidence, it was really, really common. This is 200 per 1,000 kids. 1,000 people. So it was a very common infection. I think most kids would get whooping cough. And there is still that, and then back then, I'm not sure of how many babies died, but still, about 1% of babies can die with this illness. So it was a significant illness.
Okay. Any other questions you have?
But it was very common.
Pardon?
I was saying the pertussis was, it was like everyone got pertussis, it was, and there were deaths.
Okay, so there'll be an opportunity at the end to ask more questions of Alexandra. So, John, do you want to?
Pocket? That's fine.
And how do I make the slides go? Right or left? Oh, okay. Good. The names on this list are people who made major contributions to the study, and we're happy to have at least one of the major contributors sitting there, Joanna. Bereye Trofers comes from Göteborg, Sweden. Eugenia Vinogradov comes from Ottawa, Canada, and the group worked very well and very cooperatively with each other. It was a pleasure watching them. I need help. I'm pushing a button I'm supposed to, but it ain't working. We have an expert here.
What do you want?
I want to move the slide, but I can't. Help.
No,
Are you to me? Where I come from.
there you are, my friend.
What happened?
You push the button right here. That one. Isn't that your next slide?
No. No, that's all that other stuff. Oh, you can't see the other stuff. All right, excuse me, I'm sorry. Just a little history, because this thing reminds me a little of pertussis. Before World War II, Germany realized that they wanted to have some social unrest in the United States, so they figured that they could reduce the supply of bananas easily, because all bananas came from several places in Central America, and they were shipped on white paint ships. It was called the Great White Fleet. And for U-boats, that's almost like having a target put on them. And so pretty soon we had no bananas. World War II passed, and people had not eaten bananas. In those days, bananas were eaten by poor people because each banana would be a meal. I would think it was 10 cents a banana, but my associate said they were even cheaper. Just for fun. Did you guys see The Godfather? You remember the guy who was sent to Sicily? Well, his real name was Giuseppe Bonanimo, and he was known as Joe Bananas. And during the war, the New York Times had an article that said, yes, we have no bananas today. Anyhow, take a look at the interest in the scientific and medical community to pertussis. I just copied this from the computer. Still very actively studied, even though this vaccine is quite old. We have a good vaccine, but it's not complete. And I'm going to talk to you about the history of its development and how we've tried to improve it. This is just to show it's internationally known. That's how you say pertussis in Chinese. Shao, how do you say it? No, in Chinese. Good, all right. We have an expert. Pardon? Oh, yes, when I first showed this at the University of Pittsburgh, there was a famous virologist in the audience named Montejo. So I put this slide up, and you could see he was really frowning. I said, what's the matter, Dr. Ho, is that wrong? He said, no, he said, it's upside down. And as that lovely young lady just told you, there are 3 strains that were studied initially. Only one secretes toxin. They all have the genome for the toxin, but they don't secrete it. Parapertussis causes a disease in humans. It's not so severe. Bronchoseptica causes disease in very severely treated people, but it's rare. It's mostly a disease of cattle and of dogs. I don't know anything about the other 4. How do vaccines work? They don't cure disease, they prevent disease. They prevent disease. You just have to have a critical amount of IgG antibody to the protective antigen. In this case, up to date, the only protective antigen of Bordetella pertussis in the vaccine is the toxin. The rest have nothing to do with immunity. They're just filling up space. Look at the problem. This is us, the United States. During that 10 years, pertussis was the leading cause of death in childhood. It was a major cause of death at all ages. Look at it compared to diphtheria. My family grew up on the Lower East Side, and my two aunts, the oldest aunts, died of diphtheria on the Lower East Side. It was a different age. It's still important when ranked against other diseases throughout the world, not in the United States. It's still a major cause of disease. And this is just recent. We still have pertussis to deal with. Pertussis is the only vaccine-preventable disease that is with us and looks like it's on the rise. By the way, I don't think its incidence has increased. I think it's nonsense. I think we're just recognizing the disease in the old age group. Let me tell you something about the disease. It means severe or pernicious cough. No blood cultures. It doesn't enter the circulation. It just sits on the surface of the upper respiratory tract. It's a mucosal disease. But the only thing that will prevent it is serum IgG to the toxin. My slide is better than yours. I got this from a card sent to me by a woman in France named Nikia Rousseau, who's a pertologist. This blood agar plate, that's the original Bordet gongul media. But it's not because it needs blood, it's because Bordetella pertussis doesn't have oxidative pathways. It's all micro oxidation. And that's one of the reasons that it takes 7 or 8 days to grow. It's the albumin in the blood that absorbs the fatty acids that the organisms make. You don't need blood, but blood contains albumin. Albumin or charcoal will do by itself. Now, this disease was discovered in 1906. They didn't have emails in those days. They didn't have faxes in those days. You had to go to the library and read the book. No one does that anymore. That's an ancient art. But despite the fact it was such a severe disease that the Danish government contracted with a guy named Madsen to study it. And he made a vaccine which was a fluid culture of blood and the organism. And they injected it in the Faroe Islands. I don't know if you know anything about the Faroe Islands. They're off the coast of Norway. There's no beaches. Even today, it's dangerous to land on the Faroe Islands. Very difficult. But they did a study. They did 2 experiments. And when they put them together, they concluded that even with this primitive vaccine, it would prevent pertussis. You could prevent pertussis by vaccination. Now, 2 women changed the field. The first was Pearl Kendrick and Grace Eldering, and they worked at the Michigan State Department of Health, and they devised a test for measuring the effect of injection of Bordetella pertussis in mice. Later, Margaret Pitman spent almost half a lifetime allowing unitage to be developed to this test. Margaret worked in Building 29 for most of her professional life, and we were very friendly with her before she died. There's just 2 things I'd like to tell you about her. She got a ticket driving to work when she was 92 years old for speeding. Anyone got anything better than that? But more important, she liked Chinese food. So we used to go out and eat very often with her. She was a wonderful person, an intellectual giant. With this unitage, the English studied the effectiveness of their vaccine versus the unitage given by the test. And with this technique now of being able to predict the efficacy of the vaccine, everything changed. Now, let me tell you something about this test. It's been maligned. You immunize an animal by intraperitoneal injection to prevent a respiratory infection. And then, after the animals have been injected, you inject them intracerebrally with the organism 2 weeks later. And it works. Because either with the disease or at the test, the organism don't go into the blood, they go only to one place, on the surface of the cilia of the ventricles or on the surface of the cilia of the respiratory tract. It's a malign test that's just not right. It's nonsense. Let me say something to you. The first vaccines were these whole cell vaccines, and they caused a lot of mischief. This is from an outbreak of pertussis in the University of Cincinnati in the pediatric wards, and all the nurses volunteered to participate. There were too many reactions, and so the whole cell vaccine was never recommended for adults. Not shown on the slide, I don't know why I didn't put it, but I talked to Cal Linneman when he was alive, and he said 3 of the nurses lost their memory for 4 or 5 days. So we don't inject that stuff into adults, and it did cause reactions in children, but nothing serious, just unpleasant. That's a picture of Margaret. It's a shame that she's not given more publicity. She was a very modest person. In addition to making the unitage for pertussis, she discovered Haemophilus influenza type B. She was some person. And of course, I told she liked Chinese food. Her next contribution was to point out that you could assign specific biologic activities to components of the vaccine. That changed everything, because now the geneticists and the protein chemists and the biologists could now start looking for individual components rather than working with whole cells. Now I'm going to skip a couple of decades, you won't mind. Pertussis vaccine is not one thing. The so-called acellular vaccines are mixtures, and even today people want to add things to them. It's almost as complex as chicken soup. But we don't have one thing to talk about. Unfortunately, something important has been overlooked. The only component of cellular vaccines and acellular vaccines, the only component that induces immunity is pertussis toxin antibodies. Nothing else works. And it's still in the vaccine. And the proof for this is just overwhelming. This is taken from an article studying one batch of vaccine. And if you look at the bottom, you'll see that all the experts are there. And they measured antibodies. Take a look. There's no antibodies to the filamentous hemagglutinin. It was a mutant. Never induced antibodies to filamentous hemagglutinin in the 10 years that the lead vaccine was used, and it was the most frequently used vaccine because they thought it was the best. FHA is still in the vaccine. Bananas and equator. Another component in the vaccine that's still there is protactin. There's no scientific reasoning for that at all. And what's happened recently is protactin negative strains of pertussis have been found in the United States, in fact, all over the world now. China reports them, every European country reports them. These are just as virulent as the protactin-positive strains, and I'll show you that you can't induce immunity with antibodies to this component. I'm sorry. I have good advice for all of you. Don't grow old. Listen to me. There's a new vaccine now, relatively new, with another component called Fimbria. There are 2 proteins in the vaccine. So now this protein contains 5 components. No difference between 3 components and 5 components. No difference. No statistically valid reason for putting that in the vaccine. And people want to even add more. Excuse me. Now, there's a very convincing story about Parapertussis and pertussis. It's been known for many years. Jim Cherry, who works out in Los Angeles or San Francisco, one of those places, said, I have 20 articles to show that Parapertussis does not prevent pertussis, convalescent from that disease. It doesn't work. And if you have Parapertussis, you make antibodies to pertussis toxin, shown on the bottom, but you don't make antibodies to pertussis toxin. The organism has the genome, but it does not express it, and it doesn't induce antibodies to it. Excuse me. No pertussis. But it does make antibodies to FHA, and it does make antibodies to protactin at the same rate pertussis does. But it doesn't protect, and it doesn't make antibodies to pertussis toxin, and we still have that other junk in the vaccine. There doesn't seem to be any way to get rid of it. This is a little less detailed than your slide there. It's the only one I had. But look at the top bars. Those are disease in infants and children. Then look at the bottom, and you'll see antibodies to adults. That's what is being reported. I feel confident that we're just finding it for the first time because people are thinking about it. When we worked on pertussis, how many years ago was that, Rachel? 30 years ago? 300, it seems like it. 3 people in the area that we were growing the organism caught pertussis. One poor lady coughed all the way out with her husband when they drove to California with pertussis. We brought the strain to the microbiology lab, which still is, one of the best in the world. I remember the woman's name was Blue, but she had a blue tag on. She said, we don't know how to grow pertussis. What are you growing on? That was the state of the art in the country. That's changed. We've known that pertussis in adults is not the same as infants and children. We've known this for years. People don't read. There are many articles like this. Coughing is less severe, less frequent, and people don't go to the hospital with it and they don't die with it. But I have a friend, a close friend, boyhood friend from high school. He's a professor at Columbia University Medical School, who coughed for 200 days, broke 2 ribs, and had a pneumothorax with pertussis. It's very unpleasant. Now, why are we having this disease? We have an effective vaccine that's safe, doesn't cause any reactions that are serious. None. No reactions associated with the current acellular pertussis vaccine have been reported to be serious. None. These are the causes of children not getting it, so-called personal exemptions. you have to listen to one of these guys who goes around and makes a living talking about how terrible pertussis vaccine and how it causes autism. One thing to find out, they don't work for nothing. They have huge fees, $20,000 a talk. And they work very well. I mean, you constantly hear it talk about how dangerous it is. It's not. It's a safe vaccine. But you see what happens when you don't get it. Your risk of getting pertussis goes up at least 20-fold. At least 20-fold. And many adults are not getting it today for many reasons. Internists usually are not hip about giving vaccines. They don't think about it too much. But this myth that it causes disease comes from those days of injecting wholesale vaccines with all its adverse reactions. Our friends in Sweden did a little to account for why we're having the feeling that we shouldn't allow adults to get it. I'll tell you why soon, but briefly, this is the complications of adults getting pertussis. Carefully done by high-quality internists in Göteborg, Sweden. Can you imagine coughing so much that you have a rib fracture? If you had not had pertussis and you didn't get vaccinated, if you were vaccinated for the first time over the age of 12, you're not protected. One injection of the current vaccine doesn't induce protective levels of pertussis toxin antibody. No one actually angry at that? Now, what is the cause of these increased numbers of cases? We think there are two reasons. I think it's deficiencies in this current vaccine, which is a good, safe vaccine, that permit these cases to occur. The duration of action is limited because all the components in the pertussis vaccine are proteins, and proteins do not induce lifelong levels of antibodies. Proteins do not induce lifelong levels of antibodies. Why? Now, this is a study taken from Bruce Mead, who showed that the action of pertussis toxin on cells that were activated by LPS is that the more toxin you add, the less effective the cells are. Notice how many nanograms of toxin need to be added to these cultures to show the effect. So the effect of antitoxin is to prevent pertussis toxin from immobilizing white blood cells. See, this is not a cytotoxin, and it doesn't prevent a systemic disease because it isn't systemic, it's local. So that's some of the problems encountered in making and evaluating pertussis vaccines. And more recently, investigators have shown that the opsonized pertussis organisms are not dead. They're reduced in number, but they're not dead. And that could explain why 2 cases or 3 cases of pertussis are not rare, and the organism is still circulating. That's easy to find out because pertussis occurs like measles in cycles. In our country, it's triennial cycles, and that's because after pertussis has occurred, people don't get disease for a while, and then when that number goes up again, they're infected. If you do this experiment in Greenland or in Iceland, the cycle is 7 or 8 years. It's the density of the population that counts. Now, this is the level of pertussis toxin antibodies in a population studied out west with Joel Ward and Jim Cherry and their colleagues. You see, the level goes down so that pretty soon after 2, 3, and 4 years of living, there's no more protective levels. And the disease can occur again even after the disease. So this is a fully immunized community in Michigan, right near where Pearl Kendrick worked. And as you see, they got disease again. Unfortunately, this is not commonly appreciated, not talked about. Pertussis does not confer lifelong immunity to disease. And here you can see what happens to the level of anti-protein antibodies. Diphtheria and tetanus, these are suburban adults in a well-immunized community in Minnesota. And when they took sera when they were 50 or 60 years of age, take a look at the levels. They're way below protected levels. So why don't we have diphtheria? Anyone know? We have no antibody? Don't know? The organism has disappeared. Once you immunize, the organism disappears. There's no Corynebacteria diphtheria found in the United States except in a bunch of drunk people who immigrate during the country. But if you look at antibodies to polysaccharides, and these have not been looked over long terms, this is our study, our colleague's study, and see the level of antibody in the immunized group, it's the same as the normals. Why? Because it's a highly cross-reactive substance, and we've been continually immunized by organisms other than the pathogen. There's a lovely article in the 1930s by Maxwell Finland, who showed data on antibodies to pneumococcus type 3 in people that they had cultured every month for several years, never found pneumococcus type 3. They were being induced by other antibodies, but that does not occur with a protein. Protein is too specific, too highly conservative. All right, now we're going to get to the point of the vaccine. We have time? We hardly started. If you have the disease, you make antibodies. It's immunogenic. And it does induce antibodies that are specific to the infecting agent. Pertussis makes antibodies to the LOS of pertussis, and Parapertussis makes antibodies to the LOS of Parapertussis. But these anti-protein antibodies do not kill the bacteria. So not only do they not last long, and we have disease again, they don't kill the bacteria, and that's why the bacteria is circulating. And we were stimulated to work on this by the efforts of a very good investigator, Alison Weiss, who's written extensively on the subject. She said, maybe you should make a bactericidal antibody. Well, it took about 5 years. First 5 are the toughest. The polysaccharides of Bordetella pertussis are different than all other gram-negative pathogens that we usually work with. So if we could take a picture of the surface of Bordetella pertussis and compare it to others, here's what we would find. There's an outer layer of a capsular polysaccharide. Bordetella pertussis does not have it. The next layer is what we call LPS, and that consists of 2 components, the O-specific polysaccharide and a lipid. And then if we go below the LPS, we come to something called a core, but it's not a polysaccharide, it's an oligosaccharide, and in pertussis, it's only 10 or 11 sugars. It's probably why when you get disease, you don't get too much protection because it's just not a good immunogen. It's very small. Now, you don't have to memorize this. And you can still get your name in the book. Is that all right, Evan? I just want to show you that the oligosaccharides of Bordetella, Bronchoseptica, and Pertussis are almost identical. They're not repeating units. They're composed of unusual saccharides. And what's important is if you take a look at the end of this so-called chain, it's a trisaccharide. 3 saccharides are present in Bordetella, Bronchoseptica, and Pertussis. They're identical. If you do polyacrylamide gel electrophoresis, excuse me, all of the Pertussis and Bronchoseptica have something called band A. It's present on most Pertussis, not all. If it doesn't have band A, if it doesn't have that trisaccharide, it's not virulent. So this is what the band A looks like on Bronchoseptica. You can see the trisaccharide at the end, and then we think now we know what the protective site on the molecule is. We think it's the saccharide and this glucose, which is N-acetylglucosamine. We don't know about galactose because we haven't got a mutant for it yet. Now, I would like to explain the organic chemistry of it to you, but if any of you know organic chemistry, you'll know how little I know. But to make this conjugate and make the saccharide immunogenic, we had to bind it to a protein. So if you take a protein and treat it with this compound, this region falls off, and then this is the compound that you get. If you take the LOS, or the core liposaccharides, treated with acetic acid, relatively mild conditions, the lipid falls off, and now it's just a saccharide. It has no biologic activity associated with the lipid. And if you mix this material with this unusual compound, you introduce an oxime moiety, which is very active. And these two will bind at room temperature and at reasonable concentrations and very quickly and very stable. So now we have a protein, which here we use BSA, and the reason we use bovine serum albumin is it's cheap and stable, and we don't have to worry about making a biologically active protein for the moment. And this BSA is now attached to the oligosaccharide by this oxime linkage. If you take the Bronchoseptica, you see it has 3 or 4 of those trisaccharides. But it is possible to isolate one with 1 of these trisaccharides at the edge, purified by gel filtration, not difficult. You make it highly purified. And then if you inject it, here's what you find. If there are 3 or 4 of those trisaccharides, 2 to 4, you don't get any antibody. If there's 1 next to N-acetylglucosamine, you make antibodies. So the conjugate has to have 1 trisaccharide next to the rest of the molecule. And this is what it takes to make a vaccine. There's something wrong here. This 70 fig should be red. If you watch me work the computer, you'll understand why I missed it. I'm an authentic computer dinosaur. But if you have the right concentration of the oligosaccharide on the protein, and it's of the correct length, you make bactericidal antibody. Now, these materials were only injected at a fraction of a proposed human dose in saline. No adjuvant, no intravenous injection, no intraperitoneal injection. And you see the levels of bactericidal antibody. We wanted to put them onto a useful protein because it's a conjugate. So rather than using bovine albumin, we plan to use a mutant pertussis toxin so we can make antitoxic immunity and bactericidal antibody. One molecule inducing both protective actions. That's what we suggest. We think it won't be difficult. We think if we make a bordetella pertussis lipooligosaccharide pertussis toxoid compound, we'll have something that will both act as an antitoxin inducer and also be bactericidal and reduce the organisms to almost nothing in the population. Thank you. I got to sit down. I can't stand that much.
Huh? Are there any comments? Rahel, do you have? Here you are.
Alexandra said that there is no environmental reservoir for Bordetella.
Yes.
So did anybody try comparing PCR and serological data to figure out whether there is asymptotic carriage?
Wherever that's been looked at, it's never found. If you find Bordetella pertussis organisms, I don't know about the PCR, you have pertussis. There's asymptomatic carriers, can't find them.
I actually meant if humans can carry bronchoseptica or even avium as opposed to, let's say, dogs carrying pertussis.
Pertussis is an inhabitant of and a pathogen for humans only under natural circumstances.
So dogs would carry it asymptotically?
No, they won't carry it.
John, because the organism is in the environment, do you see, or is there any indication that there's natural boosting during adulthood? Because you're given you're giving the...
Well, there's boosting to those other components, but it doesn't matter. They don't work.
No, but to the pertussis toxin.
Probably does occur, probably mild pertussis, as you know, people just don't think of it.
Mm-hmm.
And it's not easy to recover by culture.
So it may be happening, but we're not really detecting it appropriately.
I bet you that at least half the cases of pertussis are not diagnosed.
That's probably, I would say that's true. So based on where we are with current technology, should we be recommending booster shots?
Yes. You think I'm smart? You're asking, no matter what you answer, there'll be someone who's saying, no. I've learned. I don't know. I would say probably every 10 years, every 15 years. I can't answer you. Adult immunization is still a practice that's not received adequate participation by the adult internists. C'est la vie.
Speak up loudly.
Do you believe that the cellular vaccine is weaker than the cellular vaccine? Is that the cause of the upsurge in cases?
No.
It's because of diagnosis?
No, I mean, there's no good studies. The one few study with the whole cell vaccine, acellular vaccine, was made by Connaught when they had as yet an undiagnosed problem and they were injecting water.
Anyone else? Questions? Raphael, you want to comment? No? Okay.
If you want everybody to go home, I will will start singing.
All right, if there are no other questions or comments, I want to thank you both very, very much. John, thank you. It was very exciting. That's a good talk.